So my name is Jason Schillerstrom. I'm an assistant professor of psychiatry at the University of Texas Health Science Center in San Antonio, one of the docs at the med school here in town. And today we are going to talk about behavioral disturbances in elders with dementia. And then we'll also talk about caregiver burden related issues as well. And so to begin with, for behavioral disturbances elders with dementia, I think it's important to review what dementia is. And so to have dementia, you have to have memory impairment, and then you have to have another cognitive loss. And the cognitions that are specific to dementia are aphasia, which is a speech impairment, agnosia, which is a sensory impairment, apraxia, which is a motor impairment, and then executive function impairment. And so when we think about behavioral disturbances with Alzheimer's disease, a lot of times we're thinking about, or Alzheimer's disease or other dementias, a lot of times we're thinking about things like agitation and irritability, hitting, striking out, these types of problems. Or we're thinking about apathy, they're not willing to do anything, they need constant prompting, and these types of problems. And so when you look at what is it that gets people, what is it that leads to institutionalization? In general, there's two reasons why people are placed in nursing home settings. And then if we go back to our diagnosis of dementia, functional loss is another criteria. And so the reason, in general, the reason, are these going to fit? Yeah. And so in general, the reason why people are placed in nursing home settings is either because of behavioral challenges or because of functional loss. And so I don't know if I've ever met anybody, any family member, who placed their loved one in a nursing home because of memory impairment. So memory impairments are generally very tolerable. You might have to remind them, you might have to give them prompts and cues, but in general, memory impairments are not too distressing to caregivers. The reason why people eventually have to place their loved ones in long-term care facilities tends to be because of either functional loss or because of behavioral disturbances. And so functional loss kind of makes sense. If a person, if it's an older couple living at home and one of them has dementia and or even doesn't have dementia, and the other spouse can't physically help them with bathing and grooming, or they can't physically help them with toileting or feeding. If one of them is functionally dependent, if they can't meet their functional needs, and then whoever they're living with can't provide those functional needs, then they need to go to a place that can meet those needs. And so that would be nursing home or assisted living settings, depending on the amount of care that they need. And so people get institutionalized because of functional loss, or they might be able to bathe themselves, groom themselves, kind of meet the basics, but they have these behavioral problems. And so behavioral problems might be, again, things like striking out, anger, agitation, wandering behaviors would be another good example. Hypersexuality comes up quite often. Sleep disturbances, these sorts of behaviors, and that's why people go to nursing homes. It's not because of memory loss, or rarely is it just because of memory loss. And so if we look at our our criteria for dementia. Again, memory impairment, as far as transitioning to long-term settings goes, memory impairment, while it's certainly important for the diagnosis, it's less of a factor for institutionalization. Speech impairments, sensory impairments, and motor impairments, again, are less important. Executive function impairment is the big one. And so executive function impairment is what leads to an inability to care for yourself, as well as these classic behavioral disturbances. And so we can talk about, what is executive function impairment? So what is executive function and what is executive impairment? So executive function is a frontal lobe cognition. So if I was going to draw a brain, I have to, again, I hope no neurologists are watching me draw brains. But if I was going to draw a brain, this would be the brain, this would be the front, and this is the back. And so, memory is on the sides. It's in the hippocampus. Encoding, the structure that encodes memories is on the sides. It's in the temporal lobe. It's the hippocampus. But executive impairment is frontal lobe. It's all right here. So frontal lobe is executive function. And so executive function is your ability to plan, organize, sequence, monitor, and inhibit complex goal-directed behaviors. And so for my students, the way I'll describe it is it's that set of cognitions that allows you to behave independently from your environment, as opposed to having your environment dictate your behaviors. And so we can think of different examples of executive function impairment. And so right now it's the heat of the summer, but soon the holidays are coming up. And my clinic always gets lots of new consults right after the holidays. And so what will happen is it'll be the holiday season, and families will be invited over, and perhaps the older mother volunteers to make the green bean casserole. And so the green bean casserole, if it's the same green bean casserole that this older person has made for their whole lives, and if they're in their own kitchen and they have their own utensils and their own stove, their own pots and pans, there's no interruptions, then this will in fact be the best green bean casserole ever, and just like it has been for all the subsequent years. However, what happens around the holidays is it never goes like that. So around the holidays, people are invited to their daughters or their sons' homes, and now they have to make the green bean casserole with this new oven, and they just can't figure out the buttons. Or they'll be making the casserole and they get called away for a phone call, and they come back and they're trying to figure out, well, did I put the cream of mushroom soup in, or, where was I? And it's not that they've forgotten how to cook. They haven't forgotten the recipe. It's not a memory problem. It's that they can't reorganize themselves. And your ability to reorganize yourself, your ability to problem solve through the distractions, that is what executive function is. And so executive function, as it turns out, is what predicts your ability to take care of yourself. And when people become executively impaired, then that's what also seems to lead to the behavioral disturbances that we commonly see in people with dementia. And so we can talk about, what are the behavioral disturbances that we see in people with dementia? And there's a lot of them. There is, so for example, hallucinations. People will have hallucinations. And so hallucinations are where you see things that aren't there, or you hear things that aren't there. That's what a hallucination is. People will have delusions. And so with delusions, this is where you hold thoughts that are not true. So common delusions that I'll see in my clinic are people will think that there are children living up in their attic, or they'll think that people are trying to steal from them or take their belongings. They'll think that someone is trying to poison them. So these are beliefs that are not true. So hallucinations or delusions, and so these would be psychotic behavioral disturbances. We'll see irritability and agitation. And so with irritability, what we commonly think of is poor frustration tolerance. They have a hard time waiting their turn. Little things make them angry. They're less patient than they used to be. That would be irritability. For agitation, it kind of gets kicked up a notch where now they are striking out. They're trying to hurt other people. They might be more verbally aggressive, so they might start cursing and those sorts of behaviors. So irritability and agitation. We'll see apathy, where they, so for apathy, they just don't feel like doing anything. They just want to sit, and they want to get them to do anything requires prompting. They don't take baths anymore on their own. The caregivers just always feel like they're just herding them along. Dad, it's time to take your bath. You've got to take your bath. I know you don't want to take your bath. You've got to take your bath. Dad, you've got to get dressed. Dad, you've got to get out of bed. You've got to get dressed. Dad, it's time to eat. Look, here's the food. It's time to eat. So just constant prompting is needed. And so that is apathy. We'll also see sleep changes. And so people will be awake all night, wandering around the house at night. Sleep-wake cycle changes. Appetite changes are considered a behavioral disturbance. And so all of a sudden the person only wants to eat ice cream or other sweets. Might be an example of an appetite behavioral disturbance. So there's lots of behavioral disturbances. If you ask caregivers, what is the most troubling behavioral disturbance? They consistently say the same thing regardless of the population being studied. And it's always agitation and apathy are the two most distressful behavioral disturbances that are observed. And they're both equal. And so these seem opposite. Agitation is opposite to apathy. So these two seemingly opposite behaviors contribute equally to caregiver burden in model after model. And so it doesn't matter if you're looking at Alzheimer's dementia patients, vascular dementia patients, even if you're looking at people who don't have dementia. So for example, schizophrenia would be an example that has these behavioral disturbances. In people who've had traumatic brain injuries, consistently caregivers will say the hardest thing to manage is either the apathy or the agitation. And so caregivers consistently, it's agitation and apathy are the two big ones, time and time again. For functional problems, it's incontinence. That seems what comes out most commonly. What caregivers have the hardest time dealing with functionally is incontinence. But behavior-wise, it's agitation and apathy. And so you can kind of map these out. And so if you had, if this is on a behavioral scale, let's say agitation is higher than apathy. Okay, agitation. And this is apathy. So you can think of this as not enough behavior, and this is too much behavior. If you then plot out executive function or frontal lobe abilities, what you'll find, and say that your frontal lobe, this is worse frontal lobe functioning, and this is better frontal lobe functioning. If you plot these behaviors out, what you'll see is that as problem-solving abilities get worse, as executive functioning gets worse, frontal lobe functioning gets worse, people will either become more and more and more agitated or more and more apathetic. And what determines the pattern, what determines who's getting agitated from who's getting apathetic, what separates them out is what part of the cortex is affected. So what part of the brain is affected. So there are some parts of the brain where when they start to degenerate, people will become more apathetic. There's other parts of the brain where when they degenerate, they become more agitated. So it depends on the dementia type. and it depends on the stage of dementia that a person's in. But in general, as problem-solving abilities deteriorate or executive function abilities deteriorate, people will become more and more either apathetic or agitated. And again, caregivers consistently state that it's the agitation and the apathy that they just can't deal with. And it's the agitation and the apathy that leads to caregiver burden and that ultimately leads to institutionalization or placement in long-term care facilities. And so I think it is important, while we're talking about behavioral disturbances, to touch on the notion of caregiver burden. And so caregiver burden is a well-established psychiatric phenomenon that occurs in caregivers of disabled people. And it can occur at the family level, and it can also occur in professional settings. So if a person has dementia and their spouse is caring for them 24 hours a day, 7 days a week, just the act of all the care that's needed creates this depression syndrome that's called caregiver burden. However, professionals can suffer as well. So people who work in nursing home settings, like the nurses, the aides, physicians, although physicians are perfect, we never get caregiver burden. Social workers, physicians do get caregiver burden, by the way. Social workers, any person working in long-term settings can become vulnerable to caregiver burden. Just the constant act of caring for people, after a while it can add up and it can become very stressful and it can lead to depressive type conditions. And so caregiver burden does lead to depression. It's very well established that caregiver burden leads to depression. And what's also established is that caregiver burden leads to decreased physical health of the caregiver. And so just as major depressive disorder, for example, leads to decreased physical health, this 24-hour caregiving also leads to decreased physical health. And it's established that caregivers have people with high levels of caregiver burden are more likely to die sooner compared to people without this high caregiver burden. They're more likely to get sick easier. They have less of an immune response to vaccines, for example. Caregiver burden impairs the health of the caregiver. We know that. And that leads to increased morbidity and mortality. And so again, the behaviors that lead to caregiver burden most commonly are apathy and agitation, and both seem to contribute equally. So we can talk a little bit about treatments for these behavioral disturbances. And the challenge with treatments is that there's no medication that is FDA approved for dementia-related behavioral disturbances. None. And a lot of the medications that are approved for Alzheimer's disease, for example, where the target is cognition, which would be memory loss primarily, these medications don't really seem to help with behavior. There are examples in the literature where they do, where perhaps donepezil or rivastigmine or galantamine did improve behavior. But in these examples where they do help with behavior, what the literature commonly shows is statistical improvements in behavior, but not necessarily clinically meaningful improvements in behavior. So they can kind of do the math and show that there's a difference in behavior, but the caregivers don't really appreciate that there's a difference, and the math might be saying that they're better, but real life is saying that they're not. And so, so these medications that are used for dementia usually don't help with the behavioral disturbances of apathy or agitation. And so in these cases, we're almost always using off-label pharmacological interventions after we try to address the problem with non-behavioral interventions. So for apathy and agitation, in general, the first approach it's always to get a history and to determine, from the history, might we be able to identify a source of either the agitation or the apathy? So you can imagine that if you get a history and maybe the person has chronic low back pain, and so they have a pain disorder, you can imagine that this pain disorder, if their pain isn't appropriately treated, how that can lead to apathy and agitation. And so it's always nice when we can find a medical cause for excuse me. It's always nice when we can find a medical cause for the behavior disturbances. And pain is a common example in older people. If we can treat their pain, then we can relieve the apathy and agitation, and it's so nice. Other examples for apathy might be if someone has a thyroid disturbance. And so we know that when people have low thyroid hormone levels, their metabolism slows down greatly, and then that can lead to apathy. And then there's other medical examples as well. So the first step is always getting a good history and ordering appropriate diagnostic testing as a part of the data gathering process, appropriate diagnostic testing. Secondly, next, what we'll do is before we reach for medications, we always try for behavioral or psychological interventions. And so if a person is, you can imagine that if they get agitated, what might be an example? So you can imagine that if this person gets agitated with this one particular care provider, say it's in a nursing home setting and there's just this one person who is just a poor match, then just switching them to another person might be a way just to nip that behavior. Similarly with perhaps inappropriate sexual behavior, maybe the older person becomes hypersexual when they're being bathed or showered by this one particular, say it's an older man, maybe they become sexually inappropriate when they're being bathed or showered by this, perhaps a younger woman, and so just simply switching them, if possible, to perhaps a male aide instead. A lot of times that might be able to just end those types of behaviors. Lots of reassurance, lots of redirection by the aides and the nursing home staff who are trained in these interventions can help. And so we always start with behavioral interventions, reassurance, redirection, identifying the sources or the causes of the behavioral disturbances, and we try that. However, sometimes that doesn't work, and then we're kind of left with pharmacological interventions. And the efficacy of pharmacological interventions is all over the map. Sometimes they work, and sometimes they don't. Sometimes they make the problems worse, in fact. And so we can talk about general medicine strategies. And I can tell you, I can tell you my strategies, my general approach. And my general approach might not be other physicians' general approaches, but I think it's probably close. So when we're looking, when we think about using medications, the goal, when we're thinking about using medications to minimize or to treat behavioral disturbances, we want to start with the medications that are least likely to cause harm or least likely to make the problems worse. And so the medication class that we almost always start with for these behavioral disturbances are antidepressants. And so the person might not have the agitation or apathy because of depression. So they might not have clinical depression. But nonetheless, through our clinical experience, what we've noticed is that antidepressants are usually a safe way to start and usually an effective way to start. And so sometimes we're just not good at detecting depression. The person might be so cognitively impaired that we're not able to get the information that we need to diagnose them with depression. However, that doesn't necessarily mean that they're not depressed. And so starting with antidepressants, which are usually low-risk medications, is generally that is how we will begin. That'll be the first step in our pharmacological intervention. And so examples of antidepressants are medications like sertraline or venlafaxine or citalopram. Some of these you may have heard of before. So brand names for these might be Zoloft or Effexor or Lexapro or Cymbalta. There's a whole bunch of them out there. You've probably seen them advertised on television again and again and again. You probably know more of them than even I know. And so antidepressants are usually a safe way to start for agitation or apathy. For apathy, we might also use stimulants. So, for example, in my clinic, I'll use a lot of methylphenidate. Not a lot of methylphenidate, but I do use quite a bit of methylphenidate for my profoundly apathetic patients. Methylphenidate is Ritalin. And so Ritalin, you might know, that's the drug that's used to treat ADHD in little kids. But there's the regular short-acting generic methylphenidate can just get people going again. It can get them off the couch. It can keep them awake. It can keep them moving. So we use a lot of methylphenidate in my clinic. So antidepressants for agitation, stimulant medications for apathy. And then for agitation, if they don't respond to the antidepressants, usually the next step up would be sedative hypnotics, so sedatives. And so sedatives are medications like lorazepam, which is Ativan, alprazolam, which is Xanax, diazepam, which is Valium, clonazepam, which is Klonopin. So these are sedative medications. There's a risk with going up to the sedatives. And so one of the big concerns in geriatric medicine is fall risk. And in general, antidepressants aren't associated with an increased risk of falls. However, these sedative medications are. And so we don't want to use sedative medications until things are so bad that we're willing to tolerate a risk of falls. Another problem with sedative medications in older people is sometimes you can get these paradoxical reactions where you're given a sedative to treat agitation, but when they take the sedative, they actually get more agitated. And so, and these can't be predicted. The challenge is that you never know until you just try it. And then you think, are so thankful when the medication finally wears off. And so, so there are risks in using medications like Ativan, Klonopin, Xanax, Valium. There are we really got to think about it before we use these medications. So we try antidepressants, relatively safe. These are relatively safe medications that are commonly very well tolerated by elders. If that doesn't work, then we go to sedatives. And then finally, the very last type of medication that we'll talk about class is antipsychotics. And so antipsychotics are medications like olanzapine, which is Zyprexa, risperidone, which is Risperdal, and then there's a bunch of others as well. Quetiapine, which is Seroquel. And so antipsychotics are kind of the big guns in psychopharmacology. And we don't want to use these medicines unless things are so bad that that we just have no other choice. And so although these are antipsychotics, I'll have patients, I talked at the beginning about how patients might have hallucinations or delusions. And so I have patients, for example, who the TV talks to them. The TV will give them messages, and the TV will be telling them to do things. But they don't do those things. And it's essentially harmless. And yes, their mind is playing tricks on them, but it's not it's not dangerous. Or I might have patients who might see things that aren't there. They might see cats that aren't there. They might see children that aren't there. And again, the hallucinations aren't bothering them. And so if there's no distress, if the psychosis isn't impairing quality of life, then I don't treat it. I think the risks of these medications are just too great, and I don't treat it. On the other hand, if I have patients who think that there's poison coming out of the vents and they're running outside into the street, or they're keeping knives or guns under their bed, or there's dangerous acts, then we might treat those. Okay? So we don't use antipsychotics carelessly or in a cavalier way. It's our very last choice, and I hate using antipsychotics in old people. And the reason is of their side effect profile. And so in antipsychotics in elders, we have to worry about the same side effects as in younger people, which is generally muscle stiffness, Parkinsonism, where they get rigid and they can't shuffle along, or they shuffle along when they walk, drooling behaviors we'll see in younger people. So they have all the same side effects as younger people, but then in older people, these medications are associated with very high fall risks. And then most concerning is that they increase the risk of death and they increase the risk of stroke. And so if you look at placebo-controlled studies, the mortality rate in a placebo-controlled study for the placebo group is about 2%. It's a little less, but it's about 2%. If you look at the treatment group, it's about 4%. And so in medical settings, what you would do, just not to drag you through a math lesson, but I can't help myself, I'm going to drag you through a math lesson. If you take 4% and you subtract 2%, this number from that number, you get what's called the absolute risk, which is 2%. If you take 1 and you divide it by the absolute risk, you get a number that's called the number needed to harm. And so the number needed to harm, there we go. The number needed to harm in this case is 50. And so what that means is that for every 50 elders that are treated with an antipsychotic, 1 will die, and it's because of the drug. And so we don't use antipsychotics until we're willing to tolerate a 1 in 50 chance that we might kill this person with this medication. And so now it becomes existential. Now it's, well, what is your relationship with death? And for some people, a 1 in 50 chance, well, that's not all that much. And for other people, a 1 in 50 chance, oh my gosh, that's really high. And so whenever I use antipsychotic medications in elders, I'm very careful to talk with these risks to the family members, and we just don't use them until family is willing to tolerate this chance. And so you can imagine that if a person is in institutionalized care and they're so psychotic and they're acting out and they're striking out against their caregivers, and their quality of life is just so poor, then family members might be willing to tolerate the risk of these medications, and we'll try them. However, if the patient isn't there yet, then we don't use them. So we don't use these medicines until I'll have the conversation with family, and they might say, things are bad, but they're not that bad yet, and we'll try some other things, and we'll just keep trying, and maybe if those other things don't work out, then we might have to come back to this. And so that is antipsychotics in elders. We try not to use them. So again, when it comes to managing behavioral disturbances, always behavioral and psychological interventions first. We always get a good history. We're always looking to see, can we find a medical problem that is causing the behaviors? Pharmacological interventions happen last, and then we start with the medications that are likely to cause the least harm, and before we just jump straight to the medications that have very serious potential risks.